My talk today is different subjects. Subclinical renal affection in patients with beta thalassemia major in relation to chelation therapy versus blood transfusion therapy in Asut University. Beta thalassemia syndromes are a group of hereditary disorders characterized by a genetic deficiency in the synthesis of beta globin chain. This imbalance of globin chain synthesis results in ineffective erythropoiesis and severe microcytic hypochromic anemia. In beta thalassemia, profound anemia and severe hemosiderosis can cause functional and physiological abnormalities in various organ systems. There are limited studies on renal involvement in beta thalassemia, mainly involving patients on iron chelation therapy, reporting both glomerular and tubular dysfunctions. Kidney may be affected by thalassemia major at the glomerular level by lobular and segmental sclerosis and tubules by the atrophy and interstitial fibrosis. Although the main underlying causes of renal dysfunction in those patients remain unknown, the renal damage could be attributed to chronic anemia, disturbed circulation through the medullary capillaries, iron overload, iron chelation therapy, and the presence of markers of oxidative damage to tubules. Iron overload can seriously damage the tubular cell. The injured cells reverse into the interstitium, secreting growth factors and cytokines that can cause tubulointerstitial scarring and glomerular sclerosis. Differential renal direct toxicity is related to acute and irreversible renal failure, interstitial nephritis, and typical Fanconi syndrome. The mean toxic effect is changes in the renal tubular epithelial cell. The most common renal tubular abnormalities include hypercalciuria, aminoaciduria, hypomagnesemia with renal magnesium wasting, decreased tubular absorption of phosphorus, hypouricemia with renal uric acid wasting, renal glucosuria, tubular proteinuria, and low urinary osmolarity. Hypercalciuria endly leading to nephrocalcinosis. Therefore, early identification of patients at high risk of developing renal failure is one of a great importance, as it may allow specific measures to delay the progression of renal damage and thus reduces the incidence of end-stage renal failure and mortality. Cystatin C is a non-glycosylated cysteine protease inhibitor which is produced and secreted by nearly all nucleated human cells, but not renal tubules, which not reabsorbed or impact to the bloodstream. It is freely filtered by renal glomerulus and then metabolized by proximal tubule. Therefore, its serum level serves as an endogenous parameter of glomerular filtration rate. Beta-2 microglobulin is freely also filtered in the glomerulus, where it is totally reabsorbed and degraded in renal tubules. Thus, it is a sensitive marker also of glomerular filtration capacity of the kidney. Impaired excretion of beta-2 microglobulin due to glomerular damage causes an increase in its serum concentration. Therefore, their levels may serve as a sensitive marker of glomerular filtration rate, provided that inflammatory, immunologic, and neoplastic disorders that can cause increased beta-2 microglobulin level in the serum are excluded. Our aim of the work was to detect the early involvement of renal or the kidney in young patients with transfusion-dependent or independent beta thalassemia major, using both conventional and early markers of glomerular and tubular dysfunction with early identification of patients at high risk of developing renal failure. Also to study the effect of chelation therapy used on the kidney functions, and to detect the relationship between the serum ferritin and kidney functions in our patients, to correlate, finally to correlate this finding to the iron chelation therapy. 42 patients were enrolled in our study. Only 4 patients without taking a chelation therapy, while 32 patients with chelation therapy, either Devo therapy in 12 cases and DEFRA therapy in 26 cases. Also, we included 22 apparently healthy persons as controls. This study was done in hematological unit of internal medicine of Asyut University and hematology unit of pediatric hospitals in Asyut University. The all patients or participants will, the full history taking, a thorough clinical examination, including anthropometric measures, were done. And the routine investigation like CBC, liver function test, iron indices, serum ferritin, renal function test, with creatinine clearance using Schwartz formula for children less than 18 years, and Cockcroft Gold formula for those patients of more than 18 years are used. Complete urine analysis and checkup for proteinuria also were done. A specific laboratory investigations like serum cystatin and serum and urinary beta-2 microglobulin also were done. Our results showing the following. The basic characteristics of our patient between patients and control, with nothing, no statistically difference except for body mass index and height and weight of high statistically differences. Regarding the hematological characterization of our patients, we have a marked deficiency in hemoglobin level, and while the reticulocytic count was higher than controls with statistical differences of high significance. Regarding iron indices, the serum iron and serum ferritin were much higher in our patients in compared to controls. The serum beta-2 globulins and serum cystatin also were much higher than controls with higher statistically difference. Regarding their biochemical characterization as renal function, serum creat and serum urea, there's no differences in between patients and controls. However, creatinine uricosuric was much higher in our patient than controls with highly significant, statistically significant difference. Urinary beta-2 globulin also was higher in our patient in compared to controls. Our results was matched with Beheri et al. 2007, who stated that cystatin C and beta-2 microglobulin are specific and sensitive early biomarkers for monitoring glomerular and tubular dysfunction in patients with beta-2 thalassemia. When we divided our patient on 2 groups accordingly chelation therapy, the demographic data has no change between each group. However, the clinical data regarding pallor and hepatosplenomegaly and renal and osteodystrophy has a statistical difference with high statistical difference. Also, the specific markers for urinary beta-2 microglobulins and cystatin C were highly elevated in patients with chelation therapy than in those without chelation therapy with high statistical difference. Accordingly, chelation therapy, our patient demographic data has no change also or statistical difference. However, in serum iron in patient with DIFRA, patient with DIFRA had a iron overload than those without DIVO, with a highly statistical difference. Also, the urinary markers of serum, serum beta 2 microglobulins and cystatin also represent higher levels in those patients on DIFRA therapy than DIVO therapy with high statistical significance. And this was in concordance with Hamid et al., who stated that in high frequency of glomerular and tubular dysfunction in thalassemia, beta 2 thalassemia, pediatric patient, which could be attributed to oxidative stresses and DIVO therapy. All patients included were in hyperfiltration stage, either by Cockert formula or by Schwartz formula, meaning the first stage of renal affection. And this is in concordance with Keenan et al. And Gonsetli et al. Accordingly, regular transfusion state, patients with more than 10 transfusions per year have no statistical difference in renal function when compared to those of less than 10 transfusions per year. In contrast to McHam 2008, who stated that the renal disorders are not rare in patients with beta thalassemia, and they may be increased in the term of frequency with age, duration of transfusion, and desproxamine usage. When compared between our patients regarding serum ferritin using ferritin of less than 1,000 nanogram per deciliter, and that those patients of high 1,000 nanogram per deciliter, we can see that the serum create and the proteinuria is much higher in patients with those with taking with their levels of ferritin of more than 1,000 nanogram per deciliter. According to ROC curve and diagnostic accuracy of these early biomarkers compared to the conventional biomarkers, we can see that the cystatin C at a cutoff 0.7 have a highly sensitivity and specificity with beta 2 microglobulin at cutoff 3 milligram per liter than creatinine clearance and serum creatinine alone. This correlation between the increased duration of thalassemia and transfusion in our patient regarding the serum and urinary beta 2 microglobulins and cystatin C with highly statistically differences with increased duration. Also, the ferritin have a highly significant positively correlation with the both serum and urinary beta 2 microglobulin and serum cystatin. Our conclusion, renal dysfunction is a relative common complication of beta thalassemia major, and it may increase in terms of frequency with age, increased duration of transfusion, and desproxamine usage. Early identification of patients at high risk of developing renal damage is of great importance, as it may allow specific measures to be undertaken that will delay the progression of renal injury and thus reduce the incidence of renal impairment. Cystatin C is an accurate marker of renal dysfunction, and urinary beta 2 microglobulin could be considered as a reliable index of tubular toxicity and a possible predictor of proteinuria and eventual renal impairment in our patient. Therefore, routine use of these early markers of renal dysfunction is recommended. Meticulous monitoring of renal function is mandatory for those patients treated by DIFRA as the means of preventing these disturbances could be a thought. The usefulness of alternative drugs such as difeprone instead of difeprozamine should be studied further. Our recommendation, beta-2 microglobulin and cystatin C are golden indicator of renal function. Therefore, their use allow improvement management of patients. It is particularly suited to assess tubular and glomerular function, so that should be included in the follow-up scheme of those patients as a routine kidney functions that are not sensitive to help early detection. Thank you.